Hi, I'm Dr. Timothy Burroughs. I'm an interventional pain specialist at St. Elizabeth.
Hi, I'm Dr. Bradley Schulte. I'm also an interventional pain specialist at St. Elizabeth.
We work in a group of 4 physicians, all board certified in interventional pain management, and 4 nurse practitioners. We see and manage all types of pain, one of the most common being back pain. We're here to talk about how to manage back pain. An overview, I'm going to help define what pain is, some of the common causes of back pain, and why it's important to treat them. If you have an appointment in our clinic or are referred to our clinic, I'll go through what you might expect on that visit, and then Dr. Schulte is going to describe some of the interventional injection techniques and some of the minimally invasive surgical procedures that we perform. Everyone's experienced pain to some degree in some way, but when people are asked to describe pain, it's often more difficult than it seems. The International Association for the Study of Pain defines pain as an unpleasant sensory or an emotional experience associated with actual or potential tissue damage or described in terms of such damage. There's a lot of words in that definition, and it seems more complicated probably than it should, but I wanted to point out a couple of things. One, that pain is sensory and emotional, and that it's associated with actual or potential tissue damage, which is to say that the amount of pain that people experience is not necessarily associated with the severity of injury. Chronic pain is pain that lasts more than 3 to 6 months, but it also is pain that persists past when we normally expect someone who's healing to have healed from an injury. Chronic pain is very common. The CDC in 2019 estimated that more than 1 in 5 adults suffered from chronic pain, and over 7% of those adults reported that it affected their work or their life activities. So what causes back pain? Injury. We see a lot of patients that have been in motor vehicle accidents, have lifting injuries, do something repetitive that causes a functional injury. Often these injuries cause inflammation, which makes this pain persist. Sometimes there's inflammation through other diseases or injuries that exacerbates back pain. There can be fractures of the bones, tumors. There are tumors that metastasize to the spine, and tumors that show up primarily in the spine. And then there are causes of back pain that don't have anything to do with the spine. Sometimes pain from diseases of the aorta or pancreas or kidneys are referred to the back. So why is it important to treat chronic pain? It obviously can affect the quality of your life. It can affect your ability to perform duties at work or at home, and some people don't realize how it's affecting their relationships. Once your sleep is affected, it can affect your mood. You can lose interest in hobbies. You can lose interest in things that you enjoy doing. Oftentimes people don't even realize how it's affected their life until they're unable to perform their job and are in danger of losing their job. So if you get referred to our clinic, or if you make an appointment for our clinic, we'll start with an evaluation. We'll perform a detailed history, ask a lot of questions about the pain, when it started, how long it lasts, things that make it better, things that make it worse. This helps us to focus on a specific pathology. We'll do a physical exam. This may include having you do maneuvers that cause the pain or maneuvers that relieve the pain, and then we'll review your chart to see if you've had imaging of your spine. You may have had old imaging, you may have had several images, or you may have no images. Once we look at all of the available information, and after we've discussed what you're feeling and what kinds of activities and maneuvers aggravate the pain, we'll develop a diagnosis, maybe several potential diagnoses, and then review some of the treatment options. If you need additional testing, usually that's in the form of imaging. The most basic imaging is the X-ray. Typically we'll start there. If you've had an X-ray, we may need to get an MRI. If you have implanted metal that's non-compatible with MRI, we may need to get a CT. Sometimes we need a bone scan that may show tumors or may show acuity of injury. Outside of imaging, we may use a test called an EMG. That helps localize injury in specific nerves. Finally, we'll go over some potential diagnoses. There are some very common areas of the spine that are sources of pain. Discs, arthritis, narrowing of spaces in the spine, and fractured bones are all areas that are common sources of pain. Radicular pain is very common when a disc is aggravating a nerve in the spine. Typically, people will feel pain radiating down the leg in the distribution of whatever nerve is being irritated. You can see in the picture there's several different discs at different states of degeneration. At the top is a normal healthy disc. As the disc starts to dry out, it may lose some height. Sometimes as that happens and the disc loses its elasticity and bulges. If when it bulges, it irritates a nearby nerve, often you'll feel pain traveling in the distribution of that nerve, and people often call this sciatica. Another common problem when discs degenerate is the disc puts pressure on the edges of the bone. You can see on the spine, the innervation of the bone is primarily on the edges, the part of the bone that's in contact with the disc. If the disc irritates that edge of bone, you can have pain that's primarily isolated to the back. If pain is coming from those bones, you may see pain patterns like you see on the right. Pain with leaning forward, pain with prolonged sitting, pain with lifting. Arthritis is another common cause of isolated low back pain. With arthritis, the problem is on the back side of the bone, where the top bone is resting on the bone below it. A small joint is formed called the facet joint. With this type of pain, symptoms are usually aggravated with leaning backwards or prolonged standing because it exaggerates the bend in the back. A lot of times pain from arthritic facet joints is relieved when you lean forward. Arthritis can also affect a joint lower in your back, in your buttock area, or out towards your hip, called the sacroiliac joint. It's where the ilium, the crest of your waist, comes in contact with the very low part of your spine called the sacrum. This small joint moves when the pelvis rotates and is usually aggravated when you squat, when you go up steps, if you sit for a long time right on that joint, or if you lay on your side. We can often elicit pain from this joint by just pushing where those two bones come together. Another common cause of low back pain is related to narrowing of the space in the spinal canal. When this happens, we often see what's called neurogenic claudication. This is when symptoms are worse when the spine is straightened when you're standing and relieved when you lean forward or sit. This mechanical compression is related to the curvature of the spine in the low back, and you can see on the left how tight it is when the spine is straight. Fracture is another source of pain. Often this is more of an acute pain. When the bones get compressed and the bone fractures, it typically collapses down on the front edge. Often this is referred to as a compression fracture. Pain from this type of injury is usually felt over the spine where the fracture is located and often wraps around in a belt-type pattern at that same level. I reviewed several different potential sources of back pain, and the treatments vary from conservative to invasive. Conservative treatments include home exercise, ice, heat, over-the-counter medications like ibuprofen and Tylenol. On the other end of the spectrum are invasive surgical therapies. You may have heard the terms discectomy, laminectomy, or fusion. If you fail conservative therapy before moving on to the more invasive treatments, there are a lot of options in between. Sometimes the most invasive treatments lead to increased pain. They may lead to additional surgery, and the outcomes can be unreliable.
And that's where we can offer some assistance and help. Basically, we can offer something that is a little bit more invasive than the conservative treatments that have been outlined previously by Dr. Burroughs, but it would be a step below or less invasive than some of the surgical corrections like a discectomy, laminectomy, or fusion. Some of those first starting points for non-pharmacologic or non-invasive therapies include physical therapy, chiropractic therapy, things such as acupuncture, which is small needles placed in the skin, massage therapy, or even a TENS unit, which is an electric device that will help stimulate some of the muscles to relieve pain. Other options that would be on the more conservative route would be medications. There's a strategy that we like to follow that makes sure that your medications are appropriate for your condition. They have the fewest side effects while treating the condition appropriately. We start at the lowest effective dose and titrate to effect. That way we're minimizing the possibility of side effects and keeping you on an effective dose of medication to treat your pain. This is often achieved through a variety of medications used in conjunction to sort of play off of each other and help your pain in a multimodal fashion. Some of the limitations that you face with pharmacologic therapy include the side effects that you may experience. These are uncommon based on the fact that we try and mitigate those by selecting an appropriate medication for your condition, but it is not entirely preventable. If that were to happen, then we would change course and find a different treatment regimen for your pain. There's always a possibility for drug interactions. People have pain and also have comorbid conditions and other things going on in their body. A lot of people will have, say, type 2 diabetes that can lead to nerve pain as well. You have to consider interactions with the different treatment regimens between all of these things. And then you have to talk about the effect of the medication over time. Sometimes medications can lose their effectiveness and require a change of course. Some of the medications that we use commonly are things that you've seen before. Non-steroidal anti-inflammatories are one of the better medicines that we can use to treat, say, facet arthritis. These include Advil or ibuprofen, naproxen or Aleve, or diclofenac or Voltaren. Other things like acetaminophen or Tylenol are very helpful with controlling pain. When we start to add on different analgesics such as muscle relaxers like Flexeril or Robaxin or Tizanidine, we can start to assess and treat different areas of pain. There are other medications that you've most likely heard of in the neuropathic pain class. These would include gabapentin or Neurontin, or other anti-seizure medicines like Topamax. These medications can be particularly helpful in helping with nerve pain, that burning and tingling sensation that you might get in your feet. Other medications that may help with this as well include some antidepressants, such as Cymbalta, which is actually an FDA-approved medication for treatment of low back pain. Elavil or amitriptyline is another antidepressant that is effective in treatment of nerve pain. Now, once you've gone through all the other classes of medications, there's also opioid analgesics, including medications such as Tramadol, Norco, buprenorphine, or Percocet. These medications come with side effects of their own, but are effective in treating pain. You have to be very cautious with use of these medicines, as you've seen the opioid epidemic sort of ravage the community over time. So to enter into any treatment with opioids, we're very cautious about that, and we do so only appropriately. We'll start on the lowest possible dose and the lowest amount of time on that dose as needed to treat your pain. Here's a list of some of the common indications for the pain that you are feeling, okay? NSAIDs include treatment of inflammation. They're anti-inflammatory drugs at heart. They do have limitations though. Sometimes you can have side effects such as if you're on them for a longer period of time, you might damage your kidneys. You have a risk of damaging your heart. There can be drug interactions with these medicines. Tylenol is also a great medicine to use for pain. The risk you see there is if you take too much of that medication, you may have an effect on the functioning of your liver. Muscle relaxers are very good pain relievers for muscle and soft tissue pain, but sometimes they can be sedating and make it hard for you to function during the day. Neuropathic pain medications and anticonvulsants. These are great for nerve injuries or chronic pain issues. They can also be sedating. Some can cause dizziness or foggy-headedness, and they can also lead to some weight gain. Antidepressants are great for neuropathic pain as well, but they can cause mood changes. And opioids, they're reserved for severe pain and post-surgical pain. Short-term issues with these medications include addiction, dependence, development of tolerance, or opioid-induced hyperalgesia. Opioid-induced hyperalgesia occurs when you've been on this medication for a long time and you become more sensitive to things that should not necessarily be causing you pain. Outside of medications and in conservative therapies such as physical therapy, there are other things that we can do to help treat your pain, such as interventional injection therapies. One of the most common procedures that we perform is called an epidural steroid injection. Now, this may be performed for a variety of indications, including radicular pain or radiculopathy, when you might have a herniated disc impinging on a nerve that causes that sciatica type pain that people know so well. Or if you have stenosis, where there's that tightening of the spinal canal that Dr. Burroughs was describing earlier, where you get that pain and numbness and tingling in your legs and back when you start walking and you get relief with rest. That can be treated with an epidural steroid injection. Degenerative disc disease will also lead to that radicular type pain or even discogenic or vertebrogenic pain. And finally, post-laminectomy pain. Post-laminectomy refers to someone who's previously had a surgery and still has residual pain after they've had this back surgery. This is one option in treatment of that kind of pain. One of the other very common injection therapies that we offer is called a medial branch block or radiofrequency ablation. This is indicated in facet-mediated pain or arthritis. It's that pain that you feel when you lean back or rotate, predominantly in your lower back and radiating in a belt-like fashion. Now, this procedure is done, as you can see on the right side, through putting needles next to the transverse process of the vertebral body, which is where the medial branch lives. That medial branch is what innervates the facet joint itself. And so when we block that nerve, we're able to say, yes, your pain is coming from the facet joint. After we've performed this injection twice and gotten good relief with that injection, then we can proceed to a radiofrequency ablation, where we put a little bit of heat on the nerve that will denature the proteins and prevent the nerve from being able to fire that signal. Without being able to fire the signal, you don't feel that pain anymore. That's a longer lasting procedure. Typically, it can last anywhere from 6 to 12 months for most people. Now, Dr. Burroughs also described sacroiliac joint pain. That can commonly be confused with facet joint pain because they're at a similar location. But this pain is that pain that you feel when you rise from a seated position or prolonged sitting or standing. This injection is typically a little bit of local anesthetic and a steroid. The local anesthetic should give you relief that day, and the steroid will kick in approximately 48 to 72 hours to help relieve that pain. Now, progressing to slightly more invasive procedures, but still not rising quite to the level of a surgical procedure, we have a procedure such as Intercept. This is used in the treatment of vertebrogenic low back pain that has been present for greater than 6 months and has failed conservative therapy during that time period. This procedure is done in an operating room where there's a small incision made and a trocar, or essentially a metal straw, is placed against the pedicle of the vertebral body. After accessing the vertebral body, a radio frequency probe is inserted into the vertebral body next to the basivertebral nerve. Heat is applied to this nerve, much like the facet joint radiofrequency ablation. This will help deal with that pain that nothing else has really been able to cover. Vertiflex is another procedure that is predominantly used in the treatment of spinal stenosis with neurogenic claudication. That's that pain that people feel when they're standing up straight and walking. You get relief with bending over. Typically, people will describe it as they'll have to lean over on the shopping cart when they go to the grocery store. They get relief when they sit down. This procedure is also done in an operating room. There's a very small incision. You place the Vertiflex or Superion device in between the spinous process of two of the vertebrae. When this device is deployed, it will essentially flex your back for you so that you can stand up straight but still have the benefit of leaning forward. In treatment of vertebral compression fractures, there's a procedure called a kyphoplasty that we're able to perform. Now, this is similar to the intercept procedure in the fact that there is a small metal trocar placed to the pedicle of the vertebral body. Once the vertebral body is accessed, a balloon is inflated to work to restore height that has been lost from that compression fracture. After the balloon has been inflated and height has been restored, you will inject cement into that vertebral body to stabilize the compression fracture. You can see that on the right side of the slide, where that darkening is in the central vertebral body there. This is an outpatient procedure. Each level takes approximately 30 minutes, and you go home the same day. Another minimally invasive treatment that we have available for people with failed back surgery syndrome or post-laminectomy syndrome or complex regional pain syndrome or nerve root injuries or chronic neuropathy includes spinal cord stimulation or dorsal root ganglion stimulation. This therapy consists of an electrode placed in the epidural space, which will apply a small amount of energy to the dorsal columns of the spinal cord. This will affect how the pain is signaled from your extremities to your brain. Essentially, the analogy that I like to use is if you stub your toe, you get a sharp stabbing pain. You start to rub your toe, and that pain starts to go away and you feel the rubbing. That's because your spinal cord is being overwhelmed with a different signal. Functionally, your spinal cord stimulator is accomplishing the same goal. This is a therapy that is performed in 2 stages. We do a trial period where you'll have the leads implanted for 7 days attached to an external battery. During this time, you'll get to test drive it and see how it does for you. If you're happy with the results, those leads come out at the end of the trial. Then we will schedule you for a permanent implantation where we'll put those leads back into place and place a small battery beneath the skin so that you won't have any external devices on you and you'll be able to function your normal life with that therapy. Another implanted device is an intrathecal pump. This delivers medication directly to the spinal fluid. It's used predominantly in axial back pain, in folks with severe arthritis that have not responded to other treatments, to spinal stenosis, to chronic pain from compression fractures that may or may not have been able to be treated with kyphoplasty. It can be used to treat abdominal pain, or it can also be used to treat a variety of cancer pains. One of the benefits of this procedure is you're able to deliver a low amount of medication overall, but still control the patient's pain without experiencing many of the systemic side effects like constipation or itching that are associated with oral opioid therapy. This procedure is also done as a trial period where we inject a little bit of the medicine into the spinal fluid. That's a one-time injection, and you see how it goes. If you get very good relief with that, then we'd move to the operating room where we would implant a small catheter to continuously deliver the medication from the intrathecal pump, which you can see on the x-ray on the right. It's about the size of a hockey puck, but it's able to be implanted underneath the skin and refilled intermittently to provide continuous relief. Thank you for coming to our webinar today. If you have any questions at all, our number is on the slide. It is 859-212-7000. Here's a list of all of our available providers, and any one of us would be happy to answer any questions that you may have. Thank you.
Thank you.